Behavioral disorders in children, breath holding spells, bruxism, and pica. Breath holding spells reflects event age of involvement. It begins by 6 months, peaks by 2 years, and persists till 5 years. Sequence of events, provocative factors, anger, pain, baby cries, holds breath in full expiration. Type cyanotic breath holding spells due to increased sympathetic activity. Most common, cyanosis becomes normal after few seconds. If persistent, may develop tonic clonic movement. Pallid due to increased parasympathetic activity, pale and develops a syncope like attack few seconds. If persistent, ECG done to rule out long QT syndrome. Management, reassure patient benign condition with spontaneous resolution. During tonic clonic episode, turn the child sideways, which prevents aspiration. Avoid picking the child up during the event, causes sudden decreased cerebral perfusion. Evaluate and treat for iron deficiency anemia. Atropine for long-term pallid spells. Bruxism, teeth grinding, onset and occurrence, age is more than 5 years, less than 5 years is normal. Occurs during sleep, daytime bruxism associated with anxiety disorders. Long term problems, dental malocclusion and jaw pain. Treatment less than 5 years, no treatment required. More than 5 years, behavioral therapy. Pica definition, consumption of inedible non-nutritive substance like chalk, mud, and paint for at least 1 month, inappropriate for development or cultural practices. Age less than 5 years. Risk factors, malnutrition, iron deficiency anemia, low socioeconomic status, psychosocial stress, developmental delay like cerebral palsy, complication lead poisoning from pain, parasitic infestations from mud. Management, behavioral therapy, deworming, albendazole stat, low dose iron supplements 0.5 to 1 milligram per kg per day. Thumb sucking, temper tantrums, and tics. Thumb sucking. Self soothing behavior for a child. Age of involvement begins at 6 months, peaks 18 to 21 months, normal till 4 years. Management, less than 4 years, reassurance, more than 4 years indicates emotional stress, social insecurity. Behavioral modifications, positive reinforcements like praise. Avoid negative reinforcements like applying oil on thumb. Temper tantrums. Attention seeking behavior. Age of involvement begins at 18 to 36 months and persists till 6 years. Presentation, physical, emotional challenges like crying, kicking, pushing, head banging. Management, reassure and advise parents to remain calm during episode. Child to be left alone in a place where unlikely to get harmed. Distraction, taking the child away from that place. Timeout technique, leaving the child alone for some time to settle down. Tics, abrupt onset of fast involuntary paroxysmal non-rhythmic repetitive motor verbal manifestations. Age of involvement, it begins by 4 to 6 years, peak at 10 to 12 years, persists till 18 to 20 years. Types, motor tics and vocal tics. Motor tics simple complex, vocal tics simple complex. Motor tics simple, eye blinking, neck jerking, shoulder shrugging. Complex, echopraxia, repeating movements, posture, or imitating others. Vocal tics simple, repeated throat clearing, coughing, sniffing. Echolalia, repeating others' speech. Palilalia, repeating one's own words and speech. Vocal tics. Tourette syndrome. Age of onset should be less than 18 years. Motor and vocal tics for more than 1 year. Management, behavioral therapy. Long lasting tics. Tics, neuroleptics like haloperidol and clonidine. Nocturnal enuresis. Definition: nearly complete evacuation of bladder at more than 5 years, age of bladder maturation, at a wrong place and time for more than 2 times a month for more than 3 months. Incidence: males more than females. Based on etiology: primary, most common presence since birth. Etiology: functional disorder, delayed bladder maturation, decreased ADH secretion at night. Secondary: previously dry at night for at least preceding 6 months. Etiology: UTI, diabetes insipidus, diabetes mellitus, stress, bowel bladder dysfunction. Based on symptomatology: monosymptomatic, most common is passing unit at night time. Polysymptomatic, passing unit at night time plus lower urinary tract symptoms, LUTS, lower urinary tract symptoms like hesitancy, urgency, dribbling of urine, etc. Most common variety: primary monosymptomatic nocturnal enuresis. Management: motivational plus alarm therapy, highest success rate. Non-pharmacological: reassurance, behavior modification, voiding before going to bed, restrict fluids in the evening, avoid caffeine drinks, tea, coffee, soda. Motivational therapy: verbal praising, gifts if dry at night, alarm therapy, conditioning a child to sensation of full bladder, sensors put in the underwear, detects wetness and awakens child, simple alarms set to the time of usual bedwetting. Pharmacological: short-term oral desmopressin, long-term usage oxybutynin, tolterodine, decrease uninhibited bladder contraction. Imipramine not used due to adverse cardiovascular side effects. Breastfeeding